Good afternoon, everyone. On behalf of the Education and Professional Development Committee, I would like to welcome you all to today's webinar entitled New Pox on the Block, Understanding Monkeypox. We are thrilled to have Dr. Michael Bosco as our guest who will present. Dr. Michael Bosco is an infectious diseases clinical pharmacotherapy specialist at NYU Langone Hospital, Long Island in Mineola, New York. Dr. Bosco received his Doctor of Pharmacy degree from St. John's University in 2017 and completed a PGY1 and PGY2 pharmacy residency in infectious diseases at the James J. Peters VA Medical Center. Dr. Bosco is a board-certified infectious diseases and holds additional board certification as an HIV specialist. He is a member of the American Academy of HIV Medicine, the Society of Infectious Diseases Pharmacists, where he serves on the social media committee, and a delegate of the Long Island Society of Health System Pharmacists. His practice interests include antimicrobial stewardship, gram-negative resistance, management of persons living with HIV, and precepting pharmacy students as well as residents. Now, before we get started, I'd like to share a few quick points. For those who have technological issues during the presentation, please use the chat option to communicate with the office. Every effort will be made to assist in resolution. And for those who have questions that you would like to direct to the speaker, please use the question box or chat option. The CE code for this program will be provided at the end of the program. So now I'm so happy to hand it over to our speaker, Dr. Michael Bosco.
Thank you, Sefa, for the introduction, and thank you everybody for taking time out of your day to join today. So I'm very excited to give this presentation and hopefully teach everybody a couple of new things afterwards. So I have no relevant conflicts of interest to disclose. And in terms of the objectives for today, there are a couple. So the first is to understand the history of pox viruses, to then discuss the epidemiology and pathophysiology of the monkeypox virus, to review the clinical presentation and diagnosis of monkeypox virus, to learn the role of clinical therapeutics for the treatment of monkeypox virus and review pertinent clinical data, and to discuss various preventative strategies. So before I get into monkeypox specifically, it's important to understand some of the background of pox viruses. So pox viruses are considered to be some of the largest and most complex viruses in existence, and they are considered to be zoonotic pathogens, meaning infections that can transmit from animals to humans. They belong to a larger family known as the Poxviridae family, which is further broken up into several subfamilies. The first of which is the Entomopoxvirinae subfamily, which are often referred to as pox viruses of insects. So these are viruses that infect the insect population specifically. And the second subfamily where monkeypox virus falls into play is the Cortopoxvirinae family. And this is further broken up into 18 genera, which I'll show some of you later on. Moving into orthopox viruses, they're considered to be the most important and well-described poxvirus genus, specifically because of their significant impact on human and animal health and their wide host spectrum. And the most famous orthopox virus that many of you have probably heard of is smallpox, which dates to as far back as 10,000 BC and had unknown origins, and which was deemed eradicated in the 1980s following worldwide vaccination efforts. Orthopox viruses traditionally are named from the host in which they were originally identified or isolated. However, it's important to know that this does not represent the natural reservoir or true host range of these viruses, and little information is actually known about this. The transmission of orthopox viruses vary. So some viruses can transmit only to humans, whereas some can go to animals as well. For example, the variola virus only affects humans, whereas some other orthopox viruses can transmit from other mammalian species to humans and lead to outbreaks. And they can cause local versus systemic infections, and I'll get into that a little bit more. However, the local infections, specifically skin lesions, are often indistinguishable clinically. And interestingly enough, new species of orthopox viruses are still being discovered. Over the last decade, 3 new species have been discovered, most recently in 2015. So there were 4 cases of an unknown pustular rash-like illness that occurred specifically in the Fairbanks North Star Borough region of Alaska, and scientists did coin this as a new species known as Alaska pox. So this is just a breakdown starting with the Poxviridae family and then the subfamily, genus, and species. And then in the lighter purple box, you can see the clinical manifestations or the names of the diseases that these viruses can cause. But for the purposes of this presentation, we're going to be focusing on monkeypox. So talking a little bit about the epidemiology of monkeypox, the natural host, although it is called monkeypox, is unknown, and it has been isolated twice in wild animals. So specifically, the first time was in 1985 in a rope squirrel in Zaire, and then again in 2012 in a sooty mangabe, which is a species of monkey on the Ivory Coast in Africa. But subsequently, infections have been documented in other rodents and primates over the years, oftentimes ones that are intended for lab research. The first actual documented infection with monkeypox virus occurred in 1958, and this was specifically in an outbreak of pustular rash illness in another species of monkey known as crab-eating macaws that came from Singapore and arrived in Copenhagen and were intended for polio research. And it wasn't until 1970 that the first human infection with monkeypox virus occurred, and this was in a 9-month-old child in the Democratic Republic of Congo who presented with a smallpox-like skin eruption. Naturally occurring infections with monkeypox are typically confined to the forested regions of Western and Central Africa, and there's often an increased incidence of cases in these areas due to the close proximity between humans and non-human primates. And in these areas, there's an increased hunting, handling, and consumption of meat derived from these animals, which increases the risk for infection. Historically, there were different strains of the virus which were named based on the geographical regions in which they occurred. So there was the Central African strain, which was then called clade 1, and then the Western African strain, which was known as clade 2. Over the years, there's been a lot of back and forth about naming infectious diseases based on the areas where they originate, especially to avoid discrimination. So it's no longer recommended to call them the Central African strain or the Western African strain, and they typically go by clade 1 and clade 2. The other big difference amongst these clades is the mortality risk or the virulence of the clade. So clade 1 tends to be the more virulent strain, which has a higher rate of mortality as opposed to clade 2. Prior to 2022, imported cases of monkeypox in areas that were non-endemic were relatively rare. In the United States, there was a relatively large outbreak in 2003, which I'll talk about a little bit more in detail. And then in 2021, there were 2 cases, one in Texas and one in Maryland. In the UK, from 2018 to 2021, authors did report a case series of 7 cases, all which occurred or several of which occurred due to travel to Nigeria, and I'll talk about these cases a little bit more as well. And then in Israel and Singapore in 2018 and 2019, there was 1 case in each country due to travel to an area known to be endemic to monkeypox virus. Overall, the mortality associated with monkeypox varies, and in the mid to late 1900s, it was upwards of 17%, specifically in children under 10 years of age. Again, mortality with clade 1 is higher than with clade 2 due to the increased virulence of this strain specifically, and mortality is about 10% in Central Africa, whereas if you look at the mortality caused by clade 2 in the Western African areas, the mortality is lower, approximately between 3 to 4%. And mortality that occurs with clade 1 viruses more commonly occurs within the second week of illness. And interestingly enough, and important to note, what distinguishes the 2022 outbreak was that there were actually the first deaths reported in non-endemic countries. And I'll talk about those a little bit more as well. So transmission of monkeypox virus, so from animal to human transmission, it differs a little bit versus human to human transmission. So animal to human transmission can occur via a few different means, one being rodent bites or another being through close contact of infected or live or dead animals and their bodily fluids. And human to human transmission as a whole is less efficient versus smallpox, again, another orthopox virus. It's important to note that smallpox, one of the primary mechanisms of transmission is via the respiratory route, but that is not the same with monkeypox. So with monkeypox, transmission is primarily driven by direct contact with infectious sores, scabs, or bodily fluids. Respiratory transmission can occur, however, it is more uncommon for a couple of reasons. One of them is primarily because the respiratory droplets are relatively large and they don't transmit well through the airspace. And oftentimes, in order to have significant exposure or risk for transmission via this route, you have to have sustained exposure to somebody in absence of protective personal equipment or PPE for a period of time greater than 3 hours. Activities which can resuspend dried material from linen. So for example, if you have a patient that was lying in a bed and somebody comes to clean the bed or change the sheets and they shake the sheets, can actually resuspend viral materials and can potentially represent a route of transmission through the respiratory route, although again, not as commonly. Indirect transmission from fomites, so inanimate objects or surfaces, can also theoretically occur. For example, clothing or linens of a person that had monkeypox and the lesions or the bodily fluid did come in contact with the skin. And one of the things that is not relatively known at this point in time is how long can the virus survive on a surface if left undisturbed or in the absence of any disinfectants or decontamination. And we don't really know at this point in time how long the virus can survive, but there is data out there to show that other pox viruses can live for upwards of 15 days on a surface. Transmission can also potentially occur through microabrasions in the mucous membrane, so in the mouth, also transmission potentially through the eyes. And it's not well known at this time whether or not the virus can be spread via the semen or vaginal fluid, although there is emerging data to show that the virus has been detected in seminal fluid. Vertical transmission can also occur. The virus can cross placenta from mother to fetus and cause congenital monkeypox. So looking a little bit at the 2003 outbreak, so this was the first reported outbreak in the Western Hemisphere, and this occurred between May 15th and June 2003. There were 71 cases across 6 Midwestern states, Illinois, Indiana, Kansas, and some other states listed there for your reference, out of which 35 were confirmed by CDC laboratories, and the remainder were considered probable. So in this outbreak, it was actually traced back to imported Gambian pouch rats, which were shipped from Texas to an exotic animal distributor in Illinois who housed that pouched rats with prairie dogs that were ultimately destined for retail sale. So human transmission in this outbreak actually occurred due to direct contact with the prairie dogs. And patients were presenting with febrile illness and pustular rash. In this outbreak, a little over half of the patients were female, the median age was 28 years, and 26% of the patients required ultimate hospitalization. The median incubation time in this outbreak was 12 days, and no deaths were reported, and it most resembled clade 2, or that less virulent strain of monkeypox virus. And the other important thing to note in this outbreak, there were no documented human-to-human transmissions of monkeypox viruses. And ultimately, the CDC did vaccinate approximately 30, they vaccinated 30 individuals in 6 states in order to help stall the outbreak. Moving on to the 2022 outbreak, so the first cases were reported in the United Kingdom in May 2022, and they were not associated with travel to an endemic area or associated with close contact of a person known to have monkeypox. The first confirmed case in the United States was May 17th, 2022, and they did do gene sequencing of the first case and the first several cases, which matched the strains that were circulating in Europe. And the authors actually found that these cases, the gene sequences were similar to strains that circulated in a 2018-2019 outbreak in Nigeria. They did note, however, that there were increased mutations in the strains that were circulating in the United States, indicating that there were more mutations that they would have expected, raising the possibility that the virus may have been undergoing accelerated human adaptation and mutation. And because of this, they proposed that these strains didn't necessarily fall into clade 2, but they actually proposed an entirely new clade or a subclade, clade 2b. In July 2022, monkeypox was declared a public health emergency of international concern. And at that time, primary risk factors for acquisition included being an MSN or a man who has sex with other men, and specifically close contact. Now, just a couple of brief statistics. So looking at, as of September 9th, the cumulative confirmed cases, not only just worldwide, but in the United States. So as of September 9th, in the United States, there were approximately about 24,000 confirmed cases, and worldwide, it was about 55,000 or so. So these numbers are expected to be a little bit higher at this point in time. And here you can just see a little bit of a geographical distribution of the cases with the countries that are in a darker red color indicating countries that have higher cases. So you can actually see the United States has the deepest red color, showing that we are the country in the area of the world that actually has the highest amount of cases at this point in time. Daily confirmed cases are shown here again up until September 9th, but it is interesting to see that not only worldwide, but also in the United States over the last couple of weeks, cases are actually starting to come down, which is a promising sign. And it's thought to be due to increased, one, awareness of the disease, increased testing, and increased life changes that are being made by specifically the MSM community. So avoidance of specific risk factors in combination with the increased rollout of vaccines. And looking at confirmed deaths, so again, this outbreak has the first deaths that have occurred in non-endemic countries. And as of August 29th, there have been 19 confirmed deaths worldwide. So the countries that deaths have occurred are highlighted in different colors for your reference. So they include Belgium, Brazil, Cuba, Ecuador, Ghana, India, Mexico, Nigeria, Peru, Spain, and the United States. So we have had at least one confirmed death in the United States, with several others under investigation at this point in time. And the two countries with the highest number of deaths include Ghana and Nigeria. So moving on to the pathophysiology of monkeypox virus. So once it gets into the body, how does it cause infection? So the way it causes infection is pretty similar to smallpox, and overall, it's not well understood. And the primary mode of viral entry with monkeypox, as opposed to smallpox again, is via skin inoculation. So once the virus gets into the body, rapid replication occurs within lymphatic tissue. And once the virus is in the lymphatic tissue, it causes a significant lymphadenopathy as a sign of the virus multiplying within the lymph nodes. Once this occurs, this leads to a primary viremia, which leads to further dissemination of the virus into lymphoid organs. So for example, the spleen. Once the virus is able to access these lymphoid organs, it undergoes a viral amplification, which leads to a subsequent secondary viremia. And this secondary viremia causes the virus to deposit in epidermal cells. And this leads to infection, which causes the characteristic vesiculopustular lesions in the skin and mucous membranes. And further on, the virus can actually extend deeper into the dermis, which actually leads to the characteristic scarring that occurs with not just smallpox, but with monkeypox as well. In terms of the clinical presentations of monkeypox, historically, patients presented with a characteristic rash that was preceded by a viral prodrome. So a viral prodrome is often described as a flu-like illness. So patients were presenting with headache, chills, body ache, fatigue, swollen lymph nodes. And then this progressed to a rash. So in cases of monkeypox, lymphadenopathy is actually a key distinguishing factor versus something like smallpox, where it typically does not occur. And the lymphadenopathy most commonly affects the cervical lymph nodes, so the lymph nodes in the sides and the back of the neck, the inguinal lymph nodes in the groin, and the axillary lymph nodes, or those in the underarms. And the rash that patients typically or historically would present with follows what is called a centrifugal pattern. So it would start on the face and then the distal extremities, so the hands and the feet, then it would occur on the trunk, the back, and spread outwards. But with this outbreak that we're dealing with in 2022, it's really important to know that patients are presenting atypically. So there have been case reports of patients with the rash starting in the genital area, the perianal areas, with or without dissemination, so not following that traditional centrifugal pattern. Patients are also presenting with oral lesions as the predominant symptom. Some patients, it's been reported they have absolutely no viral prodrome. And other patients, specifically in the MSM community, are presenting with anorectal pain, tenesmus, rectal bleeding, and proctitis. So this is making the overall diagnosis difficult in certain cases. The incubation period of monkeypox is generally anywhere between 5 to 13 days. However, it can be upwards of 3 weeks. And it's important to note that patients are not contagious during this incubation period. And they're considered contagious once their symptoms begin, whether it's a viral prodrome or the rash that you may see. And patients remain infectious until their lesions form scabs. Those scabs fall off and a new layer of skin forms, essentially re-epithelializing. Patients may also present with nonspecific lab abnormalities, so they may have elevated liver function tests, they may have a leukocytosis or thrombocytopenia, but again, it's relatively nonspecific. The viral prodrome may last for up to 5 days, and then the rash may begin. And the rash typically begins 1 to 4 days after fever onset and subsides, and the fever subsides typically 1 to 3 days after the rash begins. And the rash typically follows a characteristic pattern, and I have a couple of examples of this lesions in different stages, which I'll show everybody. But it typically goes from a macular to a papular presentation, ultimately then to vesicular and pustular. And the number of lesions may vary. Patients may present with a few lesions, they may present with a dozen lesions, but in severe cases, patients may actually have hundreds of lesions that may be in different stages. And the lesions may also be confluent. So what this means is actually the lesions may coalesce, especially if they are closer together in an area on the body. And this coalescing of the lesions actually leads to sloughing off of the skin. And this is termed a confluent lesion. And these lesions may be extremely painful, especially depending on the area where they are. Again, they may be more painful if they're in the rectal area, if they're in the genital area, or if they're in the mouth. And once the lesions begin to heal and crust over, they become very itchy. So this is just about a time frame of where you would expect the lesions and how they would progress. So the macules are typically your flat lesions, which have a kind of pale reddish appearance. After several days, they become more of a papular appearance, which they go from a flat appearance to having a raised appearance. Several days later, they form the characteristic vesicular appearance. So again, these are raised and clear fluid-filled lesions. And then ultimately they form these pustules. So these are again raised, they have fluid filled in them, but it takes on a more pus-like appearance. And I'll show you guys some examples of that. And at this point in time, when they form this pustular appearance, they may also be called or followed what is known as an umbilicated appearance. So they have a depression within the middle of the lesion. And then ultimately the pustules remain for upwards of a week before they begin to crust. And then the entire scabbing process, when they scab over and fall off, may take 1 to 2 weeks, if not longer. So here you can see, starting on the top row and going kind of in this order, you can see an early vesicle. So it's this raised, essentially pimple-like appearance. But again, at this point in time, it's more fluid-filled. Then you can kind of see here it progressing to a pustule. Now it looks more like your traditional pimple appearance with a head. Here you can see a depression in the middle. So this is that characteristic umbilicated pustule that cases of monkeypox or smallpox may present with. This ultimately will develop ulceration and then crusting, and then the scab will detach. Here again, on the left-hand side in box A, you can see lesions in different stages. You can see some ulceration up top, and you can see again the central depression or the umbilicated lesion down here. In box B, you can see a typical pustular lesion that may present in these patients. And in box C, this is an example of potentially of a confluent lesion. So you can see how the redness that surrounds each lesion has essentially joined together and formed a much larger area of redness. And again, here, this is just another great example of the pustules that patients may present with. And again, it's important to keep in mind that these pustules can occur anywhere in the body. In terms of the outcomes of patients that do contract monkeypox, monkeypox is a self-limiting illness, and it may take up to 4 weeks for it to resolve on its own. But that doesn't mean there are not complications that may result from illness. So pulmonary disease, specifically bronchopneumonia, may develop. Patients may present with dehydration, specifically secondary to vomiting or diarrhea. Encephalitis has occurred, and there have been cases of encephalitis which have resulted in death, specifically again occurring within this current outbreak. Ocular infections may occur, which can lead to corneal scarring and permanent vision loss. And pitted scarring is the most common long-term sequelae of monkeypox virus. And again, this is permanent. So the virus can cause permanent lesions on the body. So moving on to the diagnosis of monkeypox and monkeypox virus, the accurate diagnosis requires a combination of epidemiologic, clinical, and laboratory findings. And clinicians really have to have a lot of education for when to suspect this virus, especially because it's something that many of us have not dealt with before. So there are several scenarios where clinicians should have a high suspicion. So the first is patients that present with a rash or other symptoms which may be consistent with monkeypox and that have epidemiologic risk factors. So epidemiologic risk factors in this outbreak specifically include patients who are close or intimate contacts with an individual who is known to be a confirmed monkeypox case or a suspected monkeypox case, individuals who are part of a social network who are experiencing an increased activity of cases. So in this example, in the 2022 outbreak, specifically the MSM community, anyone who has recent travel to an area known to be endemic with monkeypox virus, or patients who are presenting with genital ulcer disease or proctitis that is not responding to conventional STI treatment. So over the course of this outbreak, the recommendations from the CDC have changed in terms of, testing the number of lesions to test and what to do with the lesions. But overall, the gold standard for diagnosis is a positive PCR of the lesions. So if you look at the information that's provided by the CDC, they recommend that you have a minimum of three lesion specimens and 2 swabs per lesion. And they actually recommend that it's no longer necessary to unroof the lesions prior to testing. In the early stages of the outbreak, it was recommended to unroof the lesions, but again, that has changed over time. And you have to keep in mind that the discomfort that this may cause for the patient. And there's a questionable role of serology for making a diagnosis of monkeypox, so specifically antibody testing. There is antibody testing, so your serum IgM and IgG antibodies available. However, this cannot be used to make a diagnosis of monkeypox in absence of a positive PCR. It can help support a diagnosis, but again, on its own, it cannot be used to make a confirmed diagnosis. And one of the things that's important to keep in mind is that the onset of detectable IgM antibodies, or essentially your acute phase antibodies, which you would expect to be positive right around the time of onset of disease or when a patient is in an acute illness, varies, and it may not rise for upwards of 56 days after the rash develops. So not very useful in this situation. There are no other circulating orthopox viruses in the United States at this time, so that's another reason why monkeypox virus should be high on the differential if patients are presenting with a pus-like or a pustular-like illness. And testing can be done either at a laboratory response network site or another commercial laboratory that does have the capacity to perform the testing. So a laboratory response network essentially can perform what is known as non-variola orthopox virus-specific testing. And this confirms the presence, again, of a non-variola orthopox virus, but it does not rule in with 100% certainty that this is monkeypox. And these samples need to be sent to the CDC for confirmation for monkeypox-specific PCR. And again, it's important to consider several other things in your differential diagnosis, especially given the overlap with other infectious etiologies that may present with pustular lesions. So careful assessment is needed, and this takes into account appropriate history and physical assessment of other epidemiologic risk factors that I discussed as well. So some other infectious etiologies that may mimic monkeypox include things like varicella, which is one of the more common or more likely diagnostic considerations in a patient who may present with a vesicular rash. So again, chickenpox. And this is given the worldwide eradication of smallpox. So smallpox is not going to be something that you're commonly considering in a patient presenting with a vesicular lesion, with vesicular rash. But one of the things that you can use to differentiate varicella versus monkeypox is the presence of lymphadenopathy. So lymphadenopathy commonly occurs in patients with monkeypox, whereas with varicella or chickenpox, it is often absent. Another infection to consider is herpes simplex virus. So herpes simplex virus is another infection which can present with oral and genital lesions. However, the severity of lesions does differ depending on if it's an initial outbreak versus a recurrent outbreak. The recurrent outbreaks typically present with milder symptoms, but we do have PCR available, and this can be ruled out relatively quickly. Other sexually transmitted infections should be ruled out because there are several sexually transmitted infections that do present with genital lesions or macular rashes, specifically on the palms and soles. So they do need to be ruled out as well. So examples of some STIs that need to be ruled out include things like secondary syphilis, chancroid lesions from syphilis, granuloma inguinale, and also lymphogranuloma venereum. And then again, just for completeness sake, smallpox can be considered, but it is not a circulating orthopox virus in the United States. And we do not have any active bioterrorism at this point in time. So it's just something else to consider. And miscellaneous pox viruses, this is a possibility theoretically, but again, we don't commonly see these circulating in the United States at this time. So now moving on to the drug of the hour, what everybody wants to know more about is tecovirimat. So tecovirimat is also known under the brand name of TPOXX or the molecular entity ST246. So tecovirimat, and I'll go over the mechanism a little bit more over the next couple of slides, is an inhibitor of orthopox VP37 envelope wrapping protein. And remember that because I'll get back to that. And it was FDA approved in 2018 for the treatment of smallpox. And although it was only FDA approved in 2018 2018, specifically the oral formulation. It's actually been stockpiled in the Strategic National Stockpile under what is known as Project BioShield over the last several years in case of a bioterrorism attack, specifically weaponized smallpox. And it wasn't until 2007 that there was a first human use, specifically in a young child that developed eczema vaccinatum, which is a complication of the vaccinia or the smallpox vaccine. And this was as a result of being exposed to somebody that was vaccinated against smallpox. It does have activity versus various orthopox viruses, but it's important to note that there's no efficacy studies for either smallpox or monkeypox in humans because it is not ethical to conduct randomized controlled trials in this patient population. And it has been shown in animal models to be protective in non-human primates that are infected with monkeypox viruses and also rabbits that have been infected with rabbit pox. And an expanded access IND that was put forth in the most recent outbreak allows for use against monkeypox virus. So going into the mechanism of action a little bit further and kind of what happens when the virus gets to the cell. So the virus attaches to the cell and then gets into the cytoplasm where it undergoes a basic genetic replication. When that basic viral replication occurs, the components go into what is known as a virus factory, and they're essentially assembled into what is known as IV or immature virus. This immature virus undergoes envelopment to form what is known as IMV or intracellular mature virus, which actually undergoes further envelopment via the TGN or the trans-Golgi network and forms what is known as intracellular enveloped virus. At this point in time, this intracellular enveloped virus is infectious and it subsequently moves to the cell membrane and forms something called CEV. This CEV stands for cell-associated enveloped virus, and this ultimately forms something known as extracellular enveloped virus. And at this point in time, this extracellular enveloped virus dissociates from the cell, is fully infectious, and goes on to infect other human cells. Where tecovirimat comes into play is it blocks the conversion of the intracellular mature virus to the intracellular enveloped virus. And this process needs several proteins in order to happen. VP37 is one of them, and the tecovirimat blocks that VP37 protein. So looking at the dosing of oral tecovirimat, so it depends, it's weight-based dosing, but capsules should be taken within 30 minutes of a meal with a full glass of water. And this meal actually has to be a high-fat meal containing at least 25 grams of fat and 600 calories to increase the bioavailability. So this actually increases the bioavailability of PO tecovirimat by 39%. And treatment duration is typically 14 days. However, duration may be dependent on disease progression or clinical condition, and this is often done in conjunction with local departments of health. One thing that's important to note is the difference in dosing recommendations versus when you look at the package insert versus when you look at the emergency access protocol. So the emergency access protocol actually allows for dosing in patients that weigh under 13 kilograms, and it allows for the opening of capsules, whereas the package insert does not. There is also information provided for how clinicians or other healthcare staff can reconstitute the capsules. And this does differ again based on the age of the patient. So if, the weight of the patient. So if the patient weighs under 27 pounds, it's actually recommended that the capsules should be reconstituted with water. Otherwise, it can be mixed in another liquid such as milk or chocolate milk or sprinkled on a soft food such as applesauce or yogurt. And these reconstituted suspensions or these solutions should be used within 30 minutes of preparation. And in patients that have severe dysphagia, you can consider giving the administration via the NG tube, but I'll talk about some of the pitfalls with this in a couple of slides. Looking at the IV formulation, so again, it's important to differentiate dosing recommendations when you look at the emergency access protocol versus the package insert. So the emergency access protocol actually allows for dosing in patients under 3 kilograms, where the package insert does not. So IV tecovirimat actually is only recommended to be reconstituted in normal saline or D5W, and there's no information on its compatibility with other solutions at this point in time. And one of the things that is different about administration is it can't be administered via a traditional pump. It actually has to be given via a syringe pump over 6 hours, so a pretty long infusion time. And the reason why it has to be given via an infusion, the infusion has to be given via a syringe pump is there is actually leaching of excipient, which can occur if it's given via another mean. Reconstituted solutions should be stable for up to 24 hours if they are refrigerated. Otherwise, if they're kept at room temperature, they're stable for up to 4 hours. And in patients with latex allergies, the vial stopper is not formulated with latex, so this would be okay to use. In terms of dose adjustments, the oral formulation does not require any dose adjustments, but the IV formulation does contain something known as hydroxypropyl beta-cyclodextrin. And this actually is contraindicated if a patient's renal function is poor. So if they have a creatinine clearance of less than 30, because cyclodextrin is a known nephrotoxin. And this is somewhat reminiscent of what happened when the COVID-19 outbreak first started, when we were using remdesivir in patients that it was not recommended to use if their clearance was less than 30, again, because of the presence of cyclodextrin. Caution should be excised if you want to consider using the IV formulation in a child under 2 years of age, specifically because renal tubular function is immature and the clearance of cyclodextrin is reduced, which increases the risk for compounded nephrotoxicity. But again, in all of these cases, you have to consider risk versus benefit, often in consultation with the local departments of health and the CDC. In terms of drug interactions, overall, tecovirimat is a substrate of UGT1A1 and 1A4, and it's a weak inducer of CYP3A4 and a weak inhibitor of CYP2C9 and 2C19. So if you look at the package insert for tecovirimat, you can see this table, which I have here for your reference, which lists the significant drug interactions with tecovirimat. However, if you run this medication through a drug interaction checker, or if you look at other references as more and more data is coming out, it's showing that there may be more drug interactions than what were previously thought, based on, when you compare it to the package insert. So this is important to keep in mind, especially as clinicians get more exposure and more experience with this medication. For example, if a patient is on antiretrovirals, this is another area where you may see drug-drug interactions. So you do have to use caution, especially if you're starting a patient on tecovirimat. So looking at some of the early studies that looked at the safety of tecovirimat, so the first was a phase 3 safety, tolerability, and PK study in healthy individuals who received 600 milligrams every 12 hours of tecovirimat compared to placebo for 14 days. In this group of patients, over half were female and approximately 70% were Caucasian. And one of the patient populations that was not well represented was the elderly patient group. So 10% of patients were over the age of 65, and out of them, only 4 patients were over 75 years of age, so not well represented. But overall, the oral tecovirimat was pretty well tolerated in these patients. No huge differences in treatment, treatment-related adverse events, looking at oral tecovirimat versus placebo. And ultimately, 6 subjects did discontinue treatment because of adverse reactions. And now looking at the safety of the IV formulation. So this was another study where they looked at IV tecovirimat every 12 hours versus placebo for 7 days. The difference here, about over half of patients were male as opposed to the oral study where they were over half were female, and again, about 70% were Caucasian. So interestingly enough, if you look at the difference in IV tecovirimat versus placebo, so 26 patients versus 6, more patients in the placebo group did have infusion site swelling and erythema as opposed to the intravenous tecovirimat. And in this group of patients, 3 subjects did discontinue their treatment because of side effects. And here for your reference is just some of the PK properties of the oral versus the IV formulations of tecovirimat. Again, one of the biggest things is the effect of food on the absorption of oral tecovirimat. You have an increase in bioavailability about 40% with the oral formulation, so that's why it's recommended to give with a high-fat, calorically dense meal. The volume of distribution is pretty wide. Interestingly, it's wider with the oral formulation as opposed to the IV. And there is no urinary excretion of the IV formulation, whereas the oral formulation does have some excretion in the urine. Looking at special populations, so pregnancy and lactation. So there's no human data available at this point in time on the effects of pregnancy and lactation, but animal studies, specifically in rabbits and mice, did not demonstrate development of any embryo-fetal toxicity or abnormalities in these animals that were exposed to tecovirimat. It has been detected in the milk of lactating mice, however, but this is thought to not be of too much concern because breastfeeding is not recommended if a patient has monkeypox and active lesions, because the virus can transmit from mother to child via this route. In females and males of reproductive age, again, there's no human data, but testicular toxicity has actually been seen in mice, which has resulted in decreased fertility. So something to keep in mind as more data comes out over time. Pediatrics, there's no human data at this time, and geriatrics, we have just limited safety data. So now going on to some of the data and the clinical case reports that have come out over the last couple of years. So the first was published in 2022. So this was the case of a middle-aged man in Texas who presented to the ED with fever, cough, fatigue, nausea, vomiting, and an extensive pustular rash on his face. So this patient actually reported he had recent travel to Nigeria, and subsequently, upon his return from Nigeria to the United States, he boarded a flight despite having pustular lesions and exhibiting a typical viral prodrome, and he exposed 223 individuals to monkeypox. So the local lab network did confirm the presence of non-variable orthopox virus, which was confirmed to be monkeypox by the CDC. The patient was started on tecovirimat 600 milligrams every 12 hours, which was ultimately transitioned to IV. The reasons why he was transitioned to IV were not reported. In a lot of these case reports, some data is left out to protect patient confidentiality, but they did report complete resolution of symptoms with no treatment-associated ADRs. We don't know the time frame to the resolution of symptoms, again, because they were not reported in this case. And thankfully, there were no other documented cases of human-to-human transmission as a result of this man's travel. Now looking at an interesting case series, which was again published in 2022. So this looked at 7 patients that contracted monkeypox specifically within the UK. And the authors in this case series described the clinical presentation, complications, and management of 7 patients. And they also discussed the viral kinetics and use of brincidofovir as well as tecovirimat. So 3 patients were treated with brincidofovir and 1 patient was ultimately treated with tecovirimat. So the individual that was treated with tecovirimat was a 30 to 40-year-old female from Liverpool who contracted monkeypox from her daughter, who was actually hospitalized at that point in time. Interestingly, this patient was not vaccinated against smallpox, did not present with any viral prodrome, and did not have any lymphadenopathy. She had approximately 10 lesions amongst her face, trunk, arms, and hands, and did have detectable viral DNA in the blood and her upper respiratory tract. She was started in tecovirimat 600 milligrams orally every 12 hours on day 5 of illness, and no new lesions developed after 24 hours of tecovirimat being initiated. And she was discharged on hospital day 10 and made a full recovery. And the authors in this case series actually concluded that she had an overall shorter duration of symptoms and upper respiratory tract viral shedding compared to other patients, likely as a result of tecovirimat. So what the authors did, which was pretty cool to me, and I think it's pretty great to visualize this, is they compared the kinetics of her PCR cycles essentially. So when, as opposed to when she started treatment. So a PCR cycle refers to the number of PCR cycles required to detect monkeypox virus. And you can see that on the axis over here, with higher cycle thresholds indicating lower levels of viral DNA and a cutoff of 40 cycles indicating undetectable viral DNA samples. So you can see up top here, this dashed line indicates when the patient had an ongoing rash, and you can see she had detectable viral load in her upper respiratory tract as well as her blood. When she did start the tecovirimat, within 48 hours, the PCR became undetectable and the rash did cease to continue to progress, and she did have reported resolution of her lesions at that point in time. So you can see a pretty clear improvement based on her PCR once tecovirimat was started. And now when you look at the 3 patients that were treated with brincidofovir, so these were patients who received weekly dosing of brincidofovir. So the first patient got 1 dose, the second patient got 2 doses, and the third patient got 3 doses, each 1 week apart. You can see these patients all actually had prolonged viremia, specifically in the blood and upper respiratory tract, in addition to ongoing rash after the brincidofovir was started. And this actually led to extended isolation within the hospital. Ultimately, in all 3 of these patients, brincidofovir was discontinued because of potential liver toxicity. So now looking at some of the data from the more recent outbreak. So this is some early case reports where tecovirimat was utilized. So the first was a case of a man in his 20s who reported having unprotected sex with a man on an international trip. Initially, this patient presented with chills, malaise, and a shallow ulcer on his foreskin, which progressed to vesiculopustular lesions on his face, oropharynx, hands, feet, and pubis. This patient initially was treated for syphilis, but after testing for syphilis, gonorrhea, and chlamydia came back negative for syphilis, he was treated for HSV. He failed to improve, and the clinicians did suspect monkeypox at that point in time, and they initiated tecovirimat on day 2 of hospitalization because the patient did have these significantly painful genital lesions. After 4 days of tecovirimat, no new lesions developed from that point onwards, and the patient actually reported a decrease in the pain and itching of his lesions and reported full resolution of several lesions. He had mild LFT abnormalities on day 6 of therapy, which resolved by day 8 without discontinuation or any modification of his treatment. And he ultimately completed 14 days of treatment with reported resolution of a majority of his lesions. In another case, we have a man in his 20s with HIV that was well controlled on antiretroviral therapy who presented 7 days after anal receptive intercourse with an individual to have confirmed case of monkeypox virus. So this patient actually did receive post-exposure prophylaxis with the Jynneos vaccine, which I'll talk about a little bit more, but went on to develop fever, chills, myalgias, tonsillar pain, odynophagia, so he had difficulty and pain on swallowing, and erythematous pustules on his forearms and hands. So clinicians did decide on day 2 of hospitalization to initiate tecovirimat. He did develop additional pustular lesions on his gingiva and upper and lower extremities while he was after he was initiated on tecovirimat, but he did go on to complete 14 days of treatment with crusting of all lesions by day 9 of treatment. So this patient did go on to have full resolution of symptoms, and the only treatment-associated ADR he did experience was mild diarrhea. And in the third case, this was a man in his 40s who reported unprotected intercourse with multiple men on an international trip 8 to 10 days prior to his presentation. So he presented with malaise, fevers, and a maculopapular rash of the perineum, which actually did go on to develop that those confluent lesions in his perineum. He ultimately also had umbilicated pustules in other areas, including his eye. So the patient was started on tecovirimat because he failed to respond to broad spectrum antibiotics after 2 days. So clinicians started tecovirimat at that point in time. After 2 days of treatment, he had significant improvement in his perianal rash with resolution of a large amount of his pustular lesions. And he had near complete resolution of lesions by day 7 and went on to complete 14 days of treatment with no treatment associated ADRs. So where are we now in terms of tecovirimat in terms of treatment consideration? So under the emergency access IND, tecovirimat is actually recommended, 1, for primary or early empiric treatment. So for patients that have confirmed non-variola orthopox virus infection that are awaiting confirmatory testing by the CDC, or patients that have suspected infection where initial testing is negative and that they have a high clinical suspicion based on their clinical presentation and epidemiologic risk factors. So in these cases, it's actually recommended to initiate testing and then repeat treatment. It can also be considered for secondary treatment, so patients with complications of replication-competent smallpox vaccines. So, for example, lab workers that have inadvertent exposure, tecovirimat can be considered in combination with the vaccinia immune globulin. However, this has to be done in conjunction with the CDC, and it can be considered for post-exposure prophylaxis. However, this is only on a case-by-case basis in conjunction with the CDC. So if you look here, these are the listed criteria that the CDC have on their website. So they are only recommending tecovirimat for specific indications. So patients who have severe disease. So for example, somebody that may have those severe confluent lesions or some sort of hemorrhagic disease, patients that are at high risk of severe disease. So for those that have immunocompromising conditions, and there's some other indications listed here for your reference. But it's important to note that because we do have a relatively limited supply of this medication, the listed criteria may actually deter clinicians from seeking tecovirimat as a treatment option because their patients may not necessarily fall into one of these groups, despite the emerging benefits that we're seeing in these early case reports. So when do you want to consider IV? So you want to consider IV in a couple of different circumstances. So if a patient has swallowing difficulties, if they have swallowing difficulties, again, you can consider opening the capsules and making a suspension or putting in a soft food, as long as they're able to consume a meal. If the patient is not able to consume a meal, or if there's any concern for impaired oral drug absorption, so specifically in a critically ill ventilated patient that cannot feed by mouth, you want to consider the IV route, again, because the PO route is dependent specifically on that high fatty meal. If somebody has GI dysfunction, so maybe a Crohn's disease patient or has a history of gastric bypass where you may consider or may expect to see an issue with absorption, you may want to consider the IV route as well. So how do we obtain tecovirimat? So tecovirimat is obtained so it's released from the Strategic National Stockpile in collaboration with local or state health authorities or the CDC. There is an after hours line that clinicians can contact the CDC Emergency Operations Center if need be, but treatment essentially can begin after obtaining informed consent. And there are several other forms that are mandatory, which are listed here for your reference, but these do not have to be completed prior to initiation of treatment. The main one is the informed consent that has to be done beforehand. This has changed over time. One form that was previously mandatory was the clinical outcomes form, which was a lot of paperwork. That is no longer mandatory, so that actually cut down on the amount of paperwork that clinicians needed to complete. So talking about just kind of some of the other alternative treatments that have been proposed, cidofovir is used off-label for some things like adenovirus, BK virus, or acyclovir-resistant strains of HSV. It does have in vitro activity against monkeypox virus animal models, but again, there's no clinical data looking at the efficacy in humans, and there is significant nephrotoxicity associated with this medication. Brincidofovir is another FDA-approved agent that can be used for smallpox, but there is limited availability of this medication. It has to come from the CDC. Similar to cidofovir, it does have in vitro activity against orthopox virus infections, but again, we don't have really clinical data in humans. And if you go based on that case series in the UK, it didn't look like it did very well. Trifluridine is another option specifically for patients where we're concerned about ocular infection. So ocular infection can occur as a result of inadvertent implantation of the virus into the eye, oftentimes as a result of occupational exposure in a lab. So this medication has actually been shown in several case reports to improve recovery rates and prevent long-term damage as a result of that implantation into the eye. Again, we're concerned specifically about permanent vision loss, so this can be considered for these patients. Supportive care is also really important because these patients present with other things. They have significant itching, so you can consider antihistamines, either oral antihistamines or topical steroids. Patients with retinal lesions, you can consider prophylactic antibiotic drops or lubricating eye drops, again, to prevent corneal irritation. Patients with oral lesions, again, can be very painful, so you want to consider something like viscous lidocaine. Patients with proctitis, you want to consider medications which can help them pass stools easier or resolve or relieve pain in the area. Patients that have significant amounts of lesions may present with significant pain that requires IV narcotics, so patients may be hospitalized for multimodal pain management. And bacterial superinfection is something that we also have to take into consideration. There's no role for prophylactic antibiotics, but you want to consider giving antibiotics when there's concern for superimposed cellulitis or abscess. So these are your agents that will target your typical skin flora, so strep and staph species. And then kind of just going into the last part, so vaccination. So just looking briefly at the history of smallpox vaccination. So in 1796, Edward Jenner was a British scientist who actually demonstrated the ability to induce immunity to smallpox. So he inoculated a 13-year-old boy with cowpox and showed that it was protective against smallpox. And subsequently in 1798, the first smallpox vaccine was developed. In 1952, smallpox was actually eradicated in the United States. In 1953, it was eradicated in Europe. And in 1959, the World Health Organization said, you know, we have to ramp up our eradication efforts worldwide. We really need to focus on this. And in 1967, they really intensified their efforts. In 1977, it was deemed eradicated in Africa. And in 1980, smallpox was deemed to be eradicated worldwide. In 2001, the US actually began stockpiling smallpox vaccines in case of bioterrorism. So this is something that they've been doing over the last several decades. So smallpox vaccination or monkeypox vaccination, we'll talk about a little bit more. So smallpox vaccination utilizes the vaccinia vaccine, and it really isn't well known how well it protects against monkeypox virus or other orthopox viruses. However, there is some data to suggest that the risk of contracting monkeypox may be 5-fold lower in those that received previous smallpox vaccination. And there's two types of vaccines. There's the vaccinia virus or replication competent vaccine, which is known as Dryvax, and then which was followed by ACAM 2000. So this is a live vaccine that can undergo replication in the body. And then there's also the modified vaccinia and Cara vaccine, or the non-replicating vaccine known as Jynneos. So this vaccine is thought to be safer because it does not undergo live replication in the body. So briefly, just ACAM 2000, this was a single dose, second generation replication competent vaccine, which should not be given to immunocompromised patients because of the risk for live ongoing replication. And it's approved for immunization against smallpox. We don't really know how well it works against monkeypox virus, but there is some data in a zoonotic outbreak in 338 patients, specifically in the Democratic Republic of Congo, that showed it was about 85% effective versus zoonotic exposure. But again, no data on how well it presents for human-to-human transmission. And there's no immune correlative protection documented, which is the minimum level, threshold level of antibodies that's needed to prevent symptoms. It's thought that peak immunity is reached within 4 weeks of vaccination so 4 weeks onwards, but we don't know how long it maintains that protection. And it's recommended by ACIP to revaccinate every 3 years. This vaccine does have significant box warnings, so that is important to keep in mind. Things like myocarditis and pericarditis, encephalitis, and more severe skin complications such as progressive vaccinia and eczema vaccinata. And listed here just for your reference is some of the contraindications where you don't want to use the ACAM 2000 vaccine. So some things like patients with severe immunocompromising conditions or patients with significant cardiac risk factors. The administration of this vaccine is also very complicated, and it needs to be given via a two-pronged or a bifurcated needle. And basically what happens is a drop of the vaccine is put on the needle, and the administrator will actually give the vaccine via the percutaneous route. So it requires 15 repetitive pricks in a circular motion, and each prick is supposed to draw blood. So this is extremely painful, and patients don't really like it. And you need to observe for what is known as a vaccine take. So this is when the vaccine is actually growing at the site of inoculation. And this is a live vaccine which undergoes live replication. And it's important to note that it is transmissible. So it can be transmitted to other household contacts or immunocompromised patients. And here is just an example of what that vaccine take will look like in a patient that undergoes either a primary vaccine on the left-hand side or a repeat vaccination on the right-hand side. And it's important to note that this vaccine, the scarring is permanent and can cause permanent damage to the skin. And then briefly, the Jynneos vaccine. This is the 2-dose, more recent third-generation replication deficient vaccine that's being used. And it has, again, unknown efficacy versus monkeypox virus, but it's thought to have comparable immune response to ACAM 2000. It's thought that peak immunity is reached 2 weeks after the second dose, but similar to ACAM 2000, we don't know how long the protection lasts for. And it is a safer option for immunocompromised patients because it is not replication competent. Here are just some of the precautions that you want to take into account, which are on the CDC's website. And the way the vaccine is given now, it's actually being given via the subdermal route. And this is different versus the initial stages of the outbreak where it was being recommended to be given via the subcutaneous route. And the reason why they changed from the subcutaneous route to the intradermal route is because there was limited supply. So there was one study that showed that the intradermal route was immunologically non-inferior to the subcutaneous route, and you could actually use 1/5 of the dose. And in patients that did receive its subcutaneous route originally, they can get their second dose via the intradermal route. And this is just an example of how to give it intradermally, and the administration most closely resembles placement of a PPD. And just some quick special considerations. So in the time of COVID, if a COVID vaccine was administered first, it's not recommended to delay a monkeypox vaccine, and especially in setting of an ongoing outbreak. But if a patient received the monkeypox vaccine first and they fall into a high-risk group, specifically an adolescent or young male, it's recommended to consider waiting 4 weeks to get your COVID vaccine because of the increased risk for potentially myocarditis associated with these monkeypox vaccines and mRNA vaccines. And just lastly, post-exposure prophylaxis. So it should be given within 4 days of a known or presumed exposure. If it's given outside of that window, it's thought to have decreased effectiveness, and upwards of 14 days, it's really not to be considered, as only, unless you have a severely immunocompromised patient that had a direct exposure. And there's no benefit after symptom onset. So if a patient has symptoms, it shouldn't be given. And vaccinia immune globulin, which is only available from the CDC, can be considered specifically in immunocompromised patients that are thought to not respond well to the vaccines. So just to wrap it up, monkeypox virus, it's been around for a while. It's nothing new, but we're dealing with it now because it's not typically associated with cases in the United States. The primary mode of transmission is via close contact as opposed to the respiratory route. Patients may present with a viral prodrome and a characteristic rash, or they may not in this specific outbreak. It has a low mortality, but is associated with significant morbidity. Tecovirimat appears promising as an early option, so this definitely should be explored as more data comes out, and vaccinations can reduce the risk of developing monkeypox. So with that, I will wrap it up, and thank you everybody for participating and attending today.
Thank you, Dr. Bosco, for that riveting presentation, especially considering our current climate. I see that we have several questions in our Q&A section, but unfortunately, due to time constraints, we won't be able to address these questions for today. However, if you do have questions, please forward them to the email ceprograms@nyschp.org. That is CEPROGRAMS@nyschp.org. So that way we can forward them to Dr. Bosco to answer. And we put it in the chat as well for you.